Good morning, everyone. Presenting on behalf of Medicine 2, the Unsettled Stride. Presenting a female, Mrs. M from Bangladesh, who's a 39-year-old lady, presented with complaints of imbalance while walking since 5 years. She was apparently well until 5 years back when she developed imbalance while walking. It was insidious in onset and gradually progressive, and she felt like swaying to both sides while walking. There was no history of fall or loss of consciousness. There was no history of visual abnormality, facial deviation, hearing difficulty, voice change, regurgitation of food, or other cranial nerve deficits. No history of weakness or loss of sensation. No history of involuntary movements, tremors, or incoordination of speech. No history of headache, vomiting, convulsions, and normal bowel and bladder movements. No history of head or spine trauma, fever, night sweats. She gives a history of weight loss of 10 kgs in the last 1 year. Past history-wise, she's an ill comorbid and not on any medication. She gives a history of cerebrovascular accident 12 years back, which was not documented, following which she developed the above symptoms. And the symptoms worsened in the last 5 years. There was no significant birth history and no significant family history. She was conscious, cooperative, and oriented to time, place, and person. Vital signs normal. General physical examination findings normal. Central nervous system examination, higher mental function was normal. Cranial nerve examination, visual acuity was normal. There was slowing of eye movements. There were broken saccades and pursuits. Smell perception was normal. Facial sensations normal. No facial asymmetry. Normal hearing. Gag reflex was present. She shrugs her shoulders and no deviation of tongue. Motor system examination, she had hypotonia in all. On examination, there was hypotonia in all 4 limbs. Power of upper limb and lower limb normal. Deep tendon reflexes of the upper limb 1+. Lower limb deep tendon reflexes 2+. Plantar bilateral flexor. Superficial reflexes were present. She had an ataxic gait. Sensory system examination normal. Cerebellar signs were present. Finger nose finger test, she was unable to perform finger nose finger test and tandem walking. Dysdiadochokinesia was present, pass pointing was present, and pendular knee jerk was also present. Meningeal signs were absent, skull and spine normal. Other systemic examination findings were normal. The clinical diagnosis of chronic, symmetric, progressive cerebellar ataxia with loss of weight and pains was made, and the anatomical localization, it was localized to the medial and lateral cerebellum. Due to lack of time, we'll go into the differential diagnosis which are considered. It was a chronic 5-year history of imbalance. So the following differential diagnoses were considered: neoplastic CP angle tumors, paraneoplastic cerebellar degeneration, and metastasis from the primary breast, colon, lung, and neurodegenerative diseases like multisystem atrophy cerebellum, spinocerebellar ataxia were considered. Autoimmune causes, celiac disease, vasculitis like pan and temporal arteritis, and heavy metal toxin-induced ataxia was also considered. Metabolic causes, vitamin B12, E deficiency, Wilson's disease, and hypomagnesemia, hypothyroidism, hypoparathyroidism considered. Infections, HIV, syphilis considered. Vascular causes like vertebrobasilar insufficiency and cerebellar hemorrhage or infarction considered, and cerebellar ataxia mimics like large vessel sensory neuropathy and normal pressure hydrocephalus were also considered. The initial investigations were normal CBC, urine routine, serum electrolytes, urea creatinine, LFT was normal, HbA1c of 4.9. Serum electrophoresis showed normal pattern. There was elevated HDL, there was elevated LDL and triglycerides. Uric acid is normal. Certain investigations to rule out the differentials. MRI brain imaging and whole spine screen showed marked cerebellar, pontine, and cord atrophy, which was suggestive of a probable spinocerebellar ataxia. The other metastasis from breast, colon, lung. To rule that out, we did a CT neck, thorax, and abdomen, which showed mildly dilated esophagus and no definitive primary malignant lesions. And to rule out the autoimmune causes, we did an anti-TTG, which was negative, ANCA is a negative, ANA, CRP, ESR were negative. Heavy metal screening was negative. Other metabolic causes were ruled out. Vitamin B12 folate was normal. Vitamin E assay was awaited. Ceruloplasmin levels normal. Serum magnesium normal. TSH and PTH was also normal. Infections like HIV, syphilis, TB ruled out. BBVA screen was negative. Syphilis screen ELISA was negative. CSF showed normal findings. Cell counts of 1 per mm cube, RBCs 250 mm cube. Cytospin was showed no abnormal cells. Glucose protein was normal in CSF. MGIT was normal. It was negative. MTB was not detected. We did an EMG to rule out the sensory neuropathy differential, and that also showed a normal study, and there was no feature suggestive of normal pressure hydrocephalus on MRA. So I would like to discuss in short, in brief, about spinocerebellar ataxia, which is a progressive neurodegenerative disorder involving the cerebellum, and it could be associated with corticospinal tract involvement, also extrapyramidal involvement, sensory system could be involved, oculomotor signs could be present depending on the gene which is affected. Spinocerebellar ataxia is again consists of SCA1 up to SCA48 and still getting added. The main pathogenesis involved in SCA is the CAG repeats, the expansion of the CAG repeats. It's a main pathology, pathophysiology that is involved. And so this is a graph from Bradley's Neurology, which shows the prevalence rate of spinocerebellar ataxia in India. The commonest type is SCA2, and worldwide it's SCA3, which is common. Certain clues or certain features which are significant for each type of SCA. The age at onset. The young adult onset is more common in SCA 1, 2, 3, and 7, which are the common SCAs also. Childhood onset is present in dentatorubral pallidoluysian ataxia and SCA 7. Older adult onset is common in SCA 6. The degree of anticipation is most commonly seen in SCA 7 and dentatorubral pallidoluysian ataxia. And upper motor neuron signs are present in SCA 1, 5, and also in Maslow's-Joseph disease, which is the SCA 3. And akinetic rigid syndrome is also present in a subtype of SCA 3, which is Maslow's-Joseph disease. Chorea is prominent in dentatorubral pallidoluysian ataxia. Slow saccades are present, just like in our patient. Slow saccades are present in SCA 2, also in SCA 7. Generalized areflexia is common in SCA 2 and 4. Seizures are present in SCA 10. Dementia is present in SCA 12, 17, 27, and also in dentatorubral pallidoluysian ataxia. This is an algorithm which shows a diagnostic approach to patients with progress. Firstly, we exclude the non-ataxic disorders like normal pressure hydrocephalus, sensory neuropathy, and also frontal ataxia, in which there is ataxia present at the initiation of movements. And after excluding the non-ataxic causes, we go ahead in patients with ataxic disorders. We go ahead with an MRA imaging to rule out structural lesions like stroke or tumor or multiple sclerosis. And if atrophy is present, we go ahead and evaluate the family history. And if the family history pattern is suggestive of an autosomal dominant pattern, we consider SCA. If it is an autosomal recessive pattern, we consider autosomal recessive causes of cerebellar ataxia like Refsum's disease or some mitochondrial disorders or ataxia telangiectasia. And again, these are the most common autosomal dominant spinocerebellar ataxias. The notable ones are SCA 1, 2, 3, that is otherwise known as Maslow's-Joseph's disease, SCA 6. SCA 1, the characteristic feature, SCA 1, 2, 3 involve the ataxin 1, 2, and 3 gene respectively, involving the CAG repeats. And SCA1, the characteristic feature is the pyramidal signs, peripheral neuropathy, and ophthalmoplegia. SCA3 is Marshall-Joseph's with slow saccades and extrapyramidal signs, peripheral neuropathy. SCA2 is slow saccades without extrapyramidal signs or peripheral neuropathy. SCA6 has a very late onset, and it sometimes may lack family history also, and nystagmus is a characteristic feature of SCA6.
Gladiss, can you wrap up?
Yeah. In our patient, we gave a low-fat, low-cholesterol diet due to elevated lipid profile, and vitamin E supplements were given. The patient is planned for review after discharge with medical genetics for SCA panel analysis, for the repeat CAG expansion analysis, and also planned for review with neurology after discharge. Learning points were differentials of cerebellar ataxia, approach to cerebellar ataxia, and common forms of cerebellar ataxia.
In her case, why did you recommend a low fat?
She had deranged lipid profile. The triglycerides levels were high.
Can we put the lipid profile itself? What is the total cholesterol?
Cholesterol is 300. I'm not sure. I don't. Around 300.
300. What is the age?
39.
39.
Yeah.
Any other ASCVD risk factor? So what is the lowering strategy? Just the diet.
LDL and triglycerides?
Sorry, sir.
For LDL, triglycerides?
136 LDL, triglyceride 1.
It's on the screen.
Oh, I'm sorry. Okay.
Likely her total cholesterol would have been 300.
No, she did not have a positive family history. Yeah. No, there was no significant. I mentioned. There was no significant.
She does not have 95 positive family history.
SCA6 probably. Features of slow saccades towards SCA2. Yeah. SCA6 most because she does not have a family history significance. Probably SCA6 more than SCA2.
That's right. But is the clinical features confirming? There are no long-lasting signs at all.
Yes, sir.
Said she had a stroke 12 years ago.
It was not there was no documentation. She gave a history of stroke 12 years back. There's no documentation.
And did her symptoms start? You said it started 5 years ago. Then you also said it started after the stroke. So how long was the actual history?
The symptoms she presented with the symptoms 5 years back, but she said it started after 12 years, but it was progressive. It was worrisome in the last 5 years.
So we need to clarify the history. Your history is not clear whether the onset was 12 years ago, and also if she said stroke, what was the deficit she had at that time? What was the event that she had?
There was no documentation. It was just
what
the history.
Symptoms did she have? That's something you should clarify. Can you tell why she's got 10 kilos of weight loss over 1 year? What was the cause?
I thought it was a paraneoplastic or neoplastic etiology, and we evaluated for primary, but we could not, on imaging, we could not find any primary lesions.
Can you put the slide on your cranial nerve examination? Yeah. Cranial 1 visual activity is normal. Cranial 2 is a type. Cranial 1 is the
Olfactory.
Thyroid function stuff.
Thyroid function TSH was normal.
Thank you, Gladys. We'll close here. I think give the prize to Vineet.